Hello, everyone, and welcome to today's session called From Innovation to Impact, Rewiring Global and Regional Health Delivery at Scale. My name is Fern Lazar, and I lead Finn Partners Health Practice, and I'm so excited to be with you here today. I'm very thrilled to introduce the panelist for this session, who is Dr. Arturo LoAIza-Bonilla. And he is the Network Chair of Oncology, Hematology, and Oncology at St. Luke's University Health Network. I will ask Dr. LoAIza-Bonilla to tell you a little bit more about his illustrious background.
Thank you so much, Fern. And then nice to see everyone, and thank you for the opportunity to talk today. As mentioned, I'm the Chief of Hematology Oncology at St. Luke's University Health Network, which is a 16 hospital network in Pennsylvania and New Jersey. I'm a medical oncologist. I practice, see patients, do research. I also co-founded a company called Massive Bio, which partners globally to help patients and their physicians and caregivers to find clinical trials in real time for their cancer using AI. I'm also a professor at Temple University at the Lewis Katz School of Medicine and past president of the Pennsylvania Society of Hematology Oncology. For those who want to follow up on the things happening on a daily basis in the intersection of AI oncology and implementation. Follow me on X or Twitter or LinkedIn, whichever you feel. Always happy to engage in conversations. And thank you for the time today to be here at the firm. All right, so shall we get started? Today's lecture is going to be, or discussion about from innovation to impact, which is rewiring global and regional healthcare delivery at scale. And what this means is we want to make the implementation of technology, of emerging tools such as artificial intelligence, really making to the point where they're supposed to be at, right? Not just, hearing about it, but how we can make it meaningful for everyone to get that in a sustainable way as well in the context of the conference, right? So for those who are just learning about these things, and of course, not going to be just AI, but it's going to be as a whole discussion. But to get this started, this is not a new thing. So technology has emerged for many years. We're just hearing about them now. The same way we hear about this industrial revolution and other things that have really changed the way we operate and work as humans. AI is no exception to that. So starting when 1764 with the Bayes theorem, it was trying to determine the probability of something happening, to the first algorithm by Ada Lovelace, the first quote unquote computer, to the zeros and ones that we have from the Boolean logic that we see in the Matrix and stuff happening, and then the Turing test from Alan Turing, where we're trying to see if an algorithm was able to make us believe it was a human. And fast forward, we have actually two AI winters, and then deep learning came about with Jeff Hinton coining the neural networks, which is trying to emulate the way the brain works with neurons or perceptrons, and trying to put it into context for solving mathematical and other problems. And then we started classifying cats and then proteins. And then we had two Nobel prizes, one of them in physics and one in physiology and medicine, and with chemistry, with Emisis Havis and Jumper. And then we have the current future, which is multi-agentic AI. So this is just like a preface to show you that this is not a new thing and just part of the same framework we use for technology applications. So how can we make this happen globally? And why is this relevant, particularly in healthcare and beyond? Is because $1.4 billion have been invested just in the last year alone in healthcare AI, nearly triple compared to the prior year, over 2 times deployment compared to the broader economy. And physicians like myself were using AI tools in our practice about 66% of the time. But there's a big paradox with that, because 83% are piloting generative AI. less than 10% invested in infrastructure. And this is a place, we're talking about the United States where there's a lot of opportunity, a lot of infrastructure in place. And still, we still have a lot of issues with pilot to production. So we need that rewiring that we're talking about. And if I touch just oncology alone, just to give you an example, of course, it's going to be broad about it, but just look at the math of modern oncology. We really have to make an engineering solution because just in the United States alone, there is, a major gap that's going to happen over the last several years. The cancer treatment demand is getting incrementally increased, and the workforce is really dwindling. So, with 85% of the patients treated in community settings, so now try to look at this globally, where there's even more shortages of healthcare providers, including oncologists, and the demand just really doesn't add up. So, in by 2040, there's going to be one oncologist per 21,000 patients, right? So that's absolutely outstanding. And that's going to require an infrastructure and rewiring change. But you cannot bolt AI into a broken workflow. So we need to make sure that we redesign workflows so we can embed natively things into the clinical pathway, the way that patients come to see us and we take care of them. We had to change the governance around technology implementation, particularly around AI. And we need to show outcomes because it doesn't really matter those algorithm results and the F scores and being perfect if we don't have outcomes that help patients to live longer and live better in a fully integrated fashion. So that's part of the rewiring that we're talking about here. And there's a lot of innovation discussions, right? But there's a lot of theater too. And we're no longer debating if AI or technology works in healthcare. We're constrained by our capacity to implement it. And with that surge, the mandate is clear. We need to transition from celebrating promising point solutions to really demand auditable, sustainable infrastructure in place. And if we look globally, also there is a major need because this is just 2026. There's disruption is meeting, this point of also acceleration. So the disruption is that was a 21% decrease in assistance in healthcare in globally by decreasing, PEPFAR, USAID funding, and beyond. We have, the physician density in low median income countries is 2.3 per thousand individuals as a whole, not even oncologists, but physicians as a whole. So there's severe shortage in the workforce. And there's 20 plus countries facing acute health system strains because of these, things happening. But at the same time, we have acceleration where 30 low median income countries where AI tools are now being deployed or piloted. 95% are like have now a mandate to have increased mobile and internet penetration with readiness in metrics. And we've seen in 2026 frameworks of really working in all this in a sustainable fashion. So the question is now about the bottleneck, how we can make this happen in a larger framework as we try to align these two realities. Because the benefits are real. For every dollar that we invest in implementation of AI in healthcare, the output is $3.2 in tangible return. So it's a flywheel effect. And just now, we're seeing about 85% of healthcare leaders reporting AI actively increasing enterprise revenue, all from integration. So imagine we can optimize the lives and betterment of all those healthcare physicians and their patients in a much more robust way in intersection of high resources and also opportunity. So as we mentioned earlier, there has to be a better infrastructure, right? So durable scale happens only when those rails are shared and even when local applications differ, because we say, well, what happens in the US is not the same that happens in, Europe and Africa and Asia and Latin America. Yes, all true. But the principles are the same, right? Going to the basic principles is always important. So the pilot approaches that this happened so far is very fragmented. The return on the investment is very low, and people don't really scale. So what we need to have is a fully interoperable opportunity to integrate technology where we have software neutral specifications and common exchange rules across. That can help us to really do like a plug into national and global architectures. And I think this is something that we should focus on as part of this juncture in time. And just to give you some examples globally, so where scale demands a single operating fabric and why is it important? So three big things here to show you. So one, for example, is in India. So this was the digital mission from Ayushant Bharat, where basically almost 860 million digital records or accounts were put together with an equally number of million of records linked. They were able to do almost 409 and 49 million teleconsultations. And that basically show you that at a country level, when you put the same frameworks, you can do a telehealth that is fully stitched into a national fabric. When you go global with the WHO SMART guidelines that have been deployed not only in developed countries, but also in other countries that are up and coming, such as Ethiopia, Ghana, Malawi, Zambia, Zimbabwe, we're able to convert narrative of clinical guidelines into adaptation kits digitally and can develop better opportunities to decrease the cost of implementation of solutions and also improve the evidence-based local adaptation. And in Europe, of course, we had GDPR, we had the EU AI implementation, but that's different from other initiatives where, for example, cross-border implementation timelines with the European health data space have been successful, basically showing common rules for 27 member states which basically shares the regulatory standards so we can advance AI scale once all the regulatory hurdles have been overcome. I think there's a basic principle that I think is important beyond other regulations that are in place. But it just shows you a framework. And I always wanted to bring it to a use case. In this case, I'm a medical oncologist. I have been passionate about clinical trials for many years from my own experience as a clinician and also, my brother and family members having dealing with cancer. One example is clinical trials. So clinical trial access crisis. So in oncology, for example, um, having a patient matched to a clinical trial using technology is commoditized. Anyone can find a match. The question now is, can a system convert eligibility signal into actual access, into getting the patient to the clinical trial? Because only 3 to 5% of all cancer patients participate in trials. Most of the patients are in a community setting and rural places where less than 51, there's only 51 percent of places that actually have oncologists in regions. There are other parts that have no oncologists, they're complete deserts. So they don't even have trials or standard of care. And we want to increase opportunity. The FDA is telling us we have decentralized clinical trial opportunities. We can do telehealth. We can do local providers. We can formalize, protocols much easier, and that's opportunity. But with that comes the understanding that every patient is different and every system changes. So can we learn from this rewiring process, from other efforts to make it meaningful? Because as we all know, the same way that we think of, how we order food online and get it to our doors, or we get, groceries or technology delivered, we can do the same with clinical care and clinical trials and data. Because every patient is different, and the reality is that, as we all know, we're never static. There's a lot of dynamic changes that happen to us as individuals, and also our environment changes. But at the end of the day, well, humans will have the same framework. So can we adapt logistics for AI and clinical trials operations the same way we do it for anything else that we order online? Because it's not really different. It's just the rewiring and the mindset behind it. And of course, the first part is to solve the trust component. So something I've been working on is to combine the best of both worlds, which is you use architectures that are translatable. So architectures means looking at the zeros and ones, which is very deterministic, that's very clear, specific, and using the generative AI models to help us overcome the fast question problems, remove hallucinations, and use agentic AI to really give us the answer. So we know there's really a real clinical trial in front of us that is not hallucinated and is able to get us there. So these are the future architectures that we can use. And we proved that there was a paper that we just published where we're able to show this architecture to be auditable, explainable, and able to show how we can do this at a global scale. We don't need to have high compute. We can just do it easily locally and just complement it with the patient being in front of us to get them to clinical trials. So, but the final part is getting these patients to studies, right? So once we have the AI implemented, we know it works, we know actually the patient is eligible 100% by all parameters. We need to put the patient the same way as a UPS tracker, make sure that, or Rappi in Latin America, or Didi and somewhere else in China, the same process, right? So we all know these frameworks. Let's use it for implementation for getting the patient to where they're supposed to go using the same tools. The next level is multi-agentic AI. So agentic AI is an inflection point, means that instead of thinking of this big thing of our, what we call AGI, or, general intelligence that is just like a single thing, a supercomputer. No, we do multiple agents the same way we operate in a family or in a tumor board, where we have each specialist bring in the best to help that patient or that use case in front of us. So we can use foundational models as a baseline, which is basically information of multiple patients to guide us, but we can use agents to help us to solve the problem in front of us. So we can do it for drug discovery. We now actually has the first AI designed drug in clinical trials. We can use multi-agentic systems to really do matching of the right drug for patients, or to find biomarker opportunities for them, or to find social determinants of health in terms of things that are missing, so we understand why they can't get access to care, or to follow symptoms for them so we can flag them in real time before they end up in the hospital. And we can use AI-derived biomarkers, which are also coming up to fruition. And some of them are being shown in lung cancer, for example, that came instead of 2.5 years, they came in 5.5 months. And now we have a biomarker that predicts what patient with that specific cancer responds to specific drug that we have in front of us available. So it's all this architectural reframing that is helping us to change the future. The dual mandate is that, planetary health is a health system strategy, right? So when we talk about sustainability, it's no longer about, corporate communications or getting a certificate of EcoVadis or something like that. Is how we can think of the optimizations in technology as a way to solve problems and decrease, costs and improve, sustainability. So actually, we can decrease greenhouse emissions by being more efficient on these things, interestingly enough. The systems are evolving to use less water now. They said, oh, use AI is costing a lot of water, and actually the numbers were inflated. We're actually seeing that now the newer clusters, they are now using much less water than before, so they can cool down the systems in a much more self-sustained environment, and the technology continues to evolve. And we need much less compute now. We can actually do a lot of AI algorithms in a computer that has high power. So we know that this is all kind of comes along. So the National Academy of Medicine's Climate Collaborative team actually is talking about these decarbonization initiatives, and all can come from implementation of technology. So we do digital care orchestration, like telehealth, agentic matching, for example. We can decrease patients' need to move. We can strip out physical waste by decreasing patient travel, facility, energy, paper protocols. I tell sponsors constantly, let's support platforms that help patients to activate trials where they are, instead of spending money on paper pamphlets that no one reads, and they're sitting in a corner, and it's just increasing the carbon footprint. That is going to give a measurable environmental impact, and we can reinvest into access. We can capital reallocate to community settings, and really make it a sustainability flywheel that is going to reduce, all this carbon footprint and advance R&D. So they are compatible. We just need to rewire our brains to make sure it's this, and make the investment, because there's never, of course, there's never free lunch, but this is a good opportunity to make it big and scale, so we can see the results in real time. So just a few examples. So the NHS England Wayfinder, it decreased the CO2 emissions by actually doing digital communications instead of sending letters. So we're already seeing in the UK, for example. US telemedicine, we can decrease a significant amount of CO2 emission because of insured adults, using utilization rates using telemedicine. Vietnam WHO pilots, they saw decrease 20% of cost savings by reinvesting directly into quality improvements, decreasing the volume as well, and improving equity. In Egypt, the Attach initiative was 9% energy reduction of energy, and also 64% water use reduction we use in telemedicine in 13 hospitals. So imagine if we can do this at scale, right? If we can invest in the tools, technology, and implementation, we can do this very complementary optimization. And policy is now, building the rails, but we need to work together. So there's a lot of things happening in the United States and global. United States, we have CMS. I'm proud that Massive Bio is part of the Kill the Clipboard, and we're part of this the CMS initiatives to just do a few clicks to get patients access to medical records and use it for clinical trials. The decarbonization initiative you spoke earlier, the FDA Tempo pilot, will get technology enabled. And today we had an announcement, or today, just a couple of days, we had an announcement for an FDA to do real-time clinical trials. And TEFCA, which is the exchange of data, make it really meaningful so we don't have to be printing papers and faxes and all that stuff. Globally, we talk about WHO's scaling framework, where we have these toolkits for governments from pilot to system-wide adoption. We had the European scale health space, data space we spoke about, the Climate Collaborative, and the FDA AMA Joint AI Guidance. So all of them they're not really demonstration projects, they're really implementation tools to get them to the point of care. So the four roadblocks are, first, interoperability, so being able to connect the dots between systems, so they have to be compatible. So any system that is being built, it has to be built for openness. Governance capacity mismatches, so make sure that we have appropriate maturity level between those who are using those tools, because it's different to give my shirt to a kid that someone who is like leaner than me or bigger than me. We have to have the same level of maturity in terms of implementations. Equity at the point of use always, because we can increase digital health literacy, and that can really help us to bring those implementations to fruition and stop the pilot to reimbursement gap, basically just fund them so we can make it meaningful. So we should treat this as clinical science. The same way we go from phase 1 to phase 4 clinical trials, phase 1 safety, phase 2 efficacy, phase 3 effectiveness, phase 4 post-approval operations. We need to do deployment of AI in the same way. And this is like a phase rollout framework, like Future AI, which I think is very helpful for us to see it in that systematic way for implementation. We need to also look for centralized core architecture, but like hub and spoke, right? So the local adaptation, localize the edge for the workflows for navigation. So the patients are treated at the point of care, but we have some governance centralized to make sure that we are following the right things. So like Mayo Clinic and Mass Bio and the company will do the same, kind of keeping the same centralized for frameworks, but we are deploying it in every single place to be operated on. One thing that is important to remember is that the implementation, this rewiring, is also about knowing where are the big wins. So focus in orchestration, focus on auditable logics, and using neurosymbolic architectures is very key to optimize trust and also efficacy and quick deployments. Embed navigation and literacy support so you can get to where it's supposed to be. Carbon negative by design, not because it's the climate thing. No, it's because we can really optimize things by just being in that mindset of lean processes, right? Make it clean. Even with SpaceX go to space, they're thinking about making the rocket smaller and leaner and nicer, right? Using less fuel, same process, equally optimization. And success metrics, right? Last mile enrollments, outcomes, quality of life improvement. That's all we had to be North Star about. This rail model is what we mentioned earlier. So we had to look at first, document the clinical uses, check the risk assessment, validate it, monitor, and then check the review so we can continue to optimize it. But not all technologies are created equal, and the frameworks can be helpful, but also we need to remember that there's some oversight in different stakes. So technologies that are straightforward that we can implement right away, they don't need this extreme governance process, could be very quick and just annual review. When things are more about checking, genomic interpretation or toxicity prediction, and things are really life-threatening, then those are the ones that require the highest level of scrutiny. So we need to be mindful that we don't put all in the same umbrella because then we get nothing done or we get things done poorly. And this is one of the frameworks that we follow, the firm. So it has to be fair, has to be useful, has to be reliable, and the models have to be traceable and non-maleficent so we can follow them. And all of them is to analyze how we can implement each one of them at different steps so we can get to the maturity level that is the higher level here where we can get to level 5, which is the Kardashev maximum 2, right? Where we actually, govern the stars and been able to harness the energy to really make the benefit for all, humankind. We start in level 1, little baby steps, but we can implement further. How can we make this safely and privately? We can use federated learning models. We can use these governance models that we can do hub and spoke, as I mentioned. This is just for data governance, but we can go all over the world by deploying these things in computers, like a digital pathology implementation or a cervical cancer screening or ePROS or clinical trial matching like Massive Bio. A lot of things that we can be done when we have right framework and interoperability. So rewiring the health system delivery scale is about defining the next decade of global health when we can work together where the algorithms are really interoperable and we can make accountability for those innovations at scale in a sustainable fashion. And one example I want to give you is, for example, the work that we've been doing with the American Cancer Society. We wanted to bring clinical trials to every single patient in the United States as a whole for free using a public partnership. This is a QR code for whoever wants to get it. If you have any family member, friend, colleague, anyone who's dealing with cancer, this is for free completely for every single patient and caregiver. When you get not only that trial matching, which is the AI tool that is accurate for you, but it's also get all the benefits of sustainability that comes around with the ACS collaboration. And something that I feel is really one of those epitomes of the future of rewiring healthcare delivery at scale. We help thousands of patients now. It's time to help millions if we can, because that's going to help us to flywheel the future. We talk about the flywheel of sustainability. That flywheel also can advance science, R&D, improve trials, make just-in-time activation, get deployment at scale where you are, so you can activate the best care possible with your cell phone or computer. And we can go back to focus on the humans and being sustainable, so we can follow this Moravec's paradox, where AI does better processing pages, giving you clinical trials, monitor things 24/7, and we can focus on empathy, shared decision making, the 3 a.m. judgment call, hugging our patients and friends and family, and living a sustainable world where we can all work together. For me, this is all about this planetary AI and operations hubs, with always the patient first network, focusing on the patient in front of us. And this is not futuristic. We can do it now. It's a matter of collaboration and all that I always want to bring today as part of that. So what do we owe to the next patient? Build the rails, close the last mile, deploy AI like therapeutics, make equity sustainable, and design for the patient who is not yet in the room. So we can work together. Implementation is the real product now. The data and everything else is there for us to use. So I was finished with the Quatre Dope Spatial, which is this AI art that actually one of the few ones that actually won the fine art competition, and it shows me this good vision of the future in a combination of technology, AI, and art that makes us human. And all hopefully sustainable. So with that, I thank you for the time to talk to you today, and happy to continue the conversations with you, Fern.
I am beyond impressed, Arturo. That was, first of all, I'm inspired and hopeful, and I started out not being very encouraged when I saw the stats that you laid out at the beginning of 21,000 medical oncologists per patient in just a few years. But using that your flywheel analogies, I think we understand how we could make the system work a lot better. And I do want to touch a little bit more about the exciting work that you and your team are doing at Massive Bio, because I think it's a great case study to show how this can actually work, not just in theory, but in practice. And so maybe if you don't mind, we can just start at the beginning about your sort of what your impetus was to start this. So Massive Bio was started in 2015, and was there a defining moment or a patient experience that all of a sudden you said this clinical trial matching system as it is today is not working for the patient and we need an AI first model to intervene? What was that?
Yeah, so and thank you for that. So it came exactly from that experience. So I was working, at the University of Pennsylvania, very great place to be treated at for cancer care. And but I always saw every single patient coming to my door. They were last treatment option, just seeking for things, just try like looking for the Hail Mary miracle, which sometimes they happen. But I came about like, how is it possible that a trial was not offered to that patient like, 2 years ago, right? There was a chance there that could have been done better. And also we saw gaps in testing and gaps in treatment options. And it's
Yes,
not because they don't have any interest, like physicians like myself were very interested, but we're busy because you saw the numbers, right? So
yes,
it's really hard to give priority to a clinical trial or to optimization of biomarkers when we have a 30 patient lineup coming up in the same day.
yes,
So that really, I said, this is no different from any other potential, tool digitally that we're using. It's just different names. But same we talk about like, okay, let me use this app to build, give me the right salad that I want from my local restaurant. I should be able to find the same way from a biomarker for my cancer and get it to me. So that's where massive bio came about. So the massive bio name actually comes from massive parallel sequencing, which is next generation sequencing when we do look at the DNA footprint of the cancer and all the omics. Massive parallel computing, which is using computers and AI for that purpose. And synthetic biology, which is changing the biology because of all those things. So we were thinking about, changing the way we deliver care from the beginning, and that was the North Star from that. And we were fortunate and lucky enough that NCI heard what we were doing, and then they gave us an SBIR grant. So we started with a grant from the National Cancer Institute to build the platform, and then we just saw that this was a big opportunity to do this sustainability approach, this flywheel, where we're able to help one patient at a time and then build the whole system to make it fully sustainable. So now any patient can get it for free. The technology evolved to the point that now we can get high accuracy, and using the tools can really help anyone who comes to our door. So I think that's the nice thing about it, that we found really good use of AI in a time of need when all the things kind of came at this time at the right time. So I'm just so happy that we're able to like share this story, because it's one of those things that one patient at a time we help them. So that's
yeah,
great.
yeah. And I'm very interested in, because we do a lot of work in clinical trials, and that messy middle, as you said, is really the hard part. Is first making patients aware, and that's the part I would love to learn more about, because you have to build a big front door, and the front door has to be recognizable to every patient, no matter what part of our world they come from, no matter what language they speak, no matter their education. And so how could we do more to enable that? Because I'm confident once they get to the front door, your front door at Massive Bio, they will be escorted through the process, energetically, lovingly, etc. And we'll talk about the end, which is also where the problems arise. Again, getting them to the right trials. But how do you get that to happen? That front door part.
Yeah, it's all a matter of trying to, get as many folks, as possible to know about this because it's all about, once you're helped, then you kind of move on. Some patients help others, but they're so focused on their own cancer that it's hard for them to be like, yeah, cheerleaders of what that benefited them. So what we're doing is partnering with patient advocacy groups, with different
Great.
stakeholders. So that's why the American Society came about because we said, well, this is the largest group of oncology focused patient advocacy group. Is one of the oldest institutions in the US, and they're really doing amazing work helping everyone involved in this process. So that was a great opportunity for us to show the value. But of course, it's never enough. Because not everyone goes to the same channels. So what we continue to do is crowdsourcing of like, hey, you just need to know about it. It's free. We're helping you. This is the way to solve the future together. And I appreciate the forum today because this is, anyone should benefit from just knowing that at least the information in front of them. They may not go for the trial because it's not the right thing at that moment for them,
Right,
but at
right.
least they can guide themselves through the time.
Yes, and everybody deserves the option of saying yes or no, right? But most people don't even have that. So, and I guess you're also announcing plans to expand from clinical trial matching to drug matching. What does that evolution look like? And I know you touched on it in your presentation today, but maybe you can walk us through how that will happen and what that means also for patients.
Yeah, absolutely. So when we started as virtual tumor boards, basically trying to help end to end the patients to find all the treatment options that they had. But that was, 11 years ago, there were not the same amount of drugs that we have now. Now we have so many more.
Yes.
And it's becoming, first of all, unsustainable for any clinician to remember everything. And there's more patients coming along, and now we have drugs to give them, to offer them that they were not even available before. So now we're using the same tools for optimization to find trials, using the same heuristics, the same models, but now to tell, patients, hey, by the way, uh, you may have lung cancer and you haven't been tested for these genes. Um, Talk to your doctor, maybe get tested for this specific with a liquid biopsy or with in a blood test, you go home and just get that. And you can imagine the amount of patients that actually we have been able to quote unquote surface that they had a biomarker that they didn't know they had before. And now it's like, oh, by the way, now I have not only one trial available extra because of this, but now we have two treatment options that I don't need to go for a trial, but I'm gonna actually able to help me live longer. And we have some dramatic stories of certain patients that they really found their unique one of a kind biomarker for them. They had the right drug, and that's how they're having longer lives. So at least I tell my patients, we had to test it. Even if we find nothing, at least we leave no stone unturned. And I think that's the promise of precision medicine, to be able to look into all the different options and then help patients across their journey with that, because you never know. Like 6 months ago, we didn't have any medication for KRAS, which is one of these genes that affect pancreatic
Yeah.
cancer. Now
Yeah.
now we have Ben Sassy talking on TV, talking about his new drug that actually is making him live
Yes.
longer because we had a
Yes.
drug. So it's the same for everything. So I'm very enthusiastic because I think this is the future.
I I'm so enthusiastic to hear that, and I want to hear about how this translates. We'll talk about scale in a bit, but Massive Bio operates, as I understand it, in 18 countries and in 11 languages. And what are the most stubborn structural barriers that you see, not just in the U.S. because we certainly have ours, but also around the world that stand in the way of equitable clinical trial access, and what can so it's a two-part question. What can the technology solve, and what do we need policy for?
Uh, that's so relevant because yes, there is a lot of idiosyncrasies in every single place that you want to offer the same solutions, right? So it's
Yeah.
just interesting, but I guess it's just culture that comes along with that. The stubborn part of the whole thing is for people to see the value and to realize that this is something that unless we scale it, is going to look very small, niche, and useless. So it's always been the problem to like, hey, we need to scale this up, showing to everyone, and this is how it's going to help you and not only your patients or myself, but many others in this space. So I think that Latin America is, for example, a very open market. But then I go to Europe and it's like a super close and it's very specific about their locations, their language, and you need to adapt. So it's all about that adaptability that I feel is important. But in terms of solutions to beyond adaptability and resilience, which is, very commonplace, I think we need to have for use cases that we know that are really gonna benefit, humanity as a whole. We need to be much more open because the current structures or certain regulations and aspects are very rigid and they are therefore principle very appropriate. But this is kind of the framework that I was mentioning in my conversation, which is like not all AIs are the same. So having a tool that is giving you to able to pull information just to show you what you have and what you can use, and you are the one owning that journey, is much different than something that tells you, "I'm sorry, you cannot get this drug. You need to get this drug, and this is it." Uh, that's a much different framework. But right now, everything is put under the same umbrella. So the I think the WHO and the EU and others, they need to kind of okay that at the beginning when you're afraid of things you kind of like blocked up and say this is the way,
Yeah.
but now you had to like okay no we had to be more nimble, we had to be more open and find that every use case, particularly the one that helps everyone, should be much more open and transparent and explainable. So I think that's something that we should definitely work on together.
If you were to send a message to every health system administrator, payer, executive, government health minister who may be hopefully watching this session today, what would you say to them?
Let's work together. Let's collaborate. This is something that it cannot be done by a single company, individual, group. We are here, we're all humans. We all suffer from the same diseases, in particular
Yes.
cancer. And this is something that the only way to, cure cancer as a whole, as we see it, as we know it, is first clean up the operational aspect of it, which is extreme hurdle. And it can be done by working together using technology. I would love to be part of the conversations, tell you my stories. I have a double PhD now on clinical trial recruitment and engagement after working 11 years in the space, plus, caregiving and oncologist. So I think it's all about let's work together, learn about what MassiBio does. Let's try to make it implementable across and open the fields, break the silos, and work together for the future.
So interesting. And I'm encouraged that you have AI right in the middle of your name. So I think you are the right guy to do this.
I was destined for
You were destined,
that.
yes. So when we were talking about scale in terms of, getting to the next level with some of these great innovations, and that often means standardization. But here we are, we're talking about precision care, which is inherently all about personal care for every individual genome and, all the rest of the phenotypes, et cetera. So how do you reconcile it? When does the standardization part come in and when does the personalization part come in?
And that's such a relevant question. So generalization is mostly about equity, right? Making sure that we're not missing anyone from the algorithm and that we all benefit from it. That's where we have those broader frameworks of standardization. The personalization always comes to the individual level, of course, makes sense, but it basically is what can we use for that specific location or patient that is going to solve the barrier and really bring that equity end to end. So either by solving the digital divide because those patients don't have internet and then just get Starlink or whatever you want to do, or give them a cell phone, or two, remove the barrier. So even if they have a cell phone, then you allow for that clinical trial to be delivered at the point of care where they are. And that happens not only in other countries. In the US is very prominent. We centralize everything. And everyone's like, I'm the best, all these rankings and tribalism, and as my team is better than yours, sure. But I moved to other place, and then now my team is better than yours because I moved there. We're all the same, and it's all a matter of like meeting the patient where is there. So if my dream, particularly around clinical trials, is that you have my cell phone now. I get a pre-screen for all my treatment options is that I'm missing this biomarker to get it tested. I know my cancer type. I know the trials that are available, and there's a menu, and I can activate it with my cell phone, and then I get the treatment under standard of care that everyone gets with my doctor locally that is just like 10 miles away from me. And the very special drug, it comes from a drone or it comes from a phone or it comes from anywhere, and I can get it in another facility, but everyone's sharing that love. Right now, everything is you either get with me or without me. I'm the
Yeah.
cancer research center, I'm the community center. No, we're all
Yes. Yes.
oncologists. There's nothing different. This protocol, there's a reason why it's called protocol, because it's a book, it's a recipe book, and it's like read it, follow the
Yeah.
protocol, and be done. That's what we need to
And
do.
what are the people who live in, in rural areas where there are hardly any medical oncologists, and they have to travel 2, 4, 6 hours to get to the nearest facility. So they need a model like this, which brings the best care closer to them.
100%. And there is the impetus. There is now the funds for rural healthcare as well, $50 billion across the states. I can imagine having, we have 19,000 clinical trials maximum every year open, and we have 2 million cancer patients per year. We can fill every single slot on a day, and still
Would be
50% go without being completed. 60% of clinical trials don't even complete enrollment because of lack of patients. So that
yes,
tells you the crazy disconnect that is just an operational dream, right? Someone who's a CIO is like,
yes.
I'm going to solve this round, right?
I'm an economist by training, and I hear, supply and demand everywhere here in this equation, right? And there's, unfortunately, we have lots of barriers in between. But you mentioned I was very excited also to see the FDA's announcement about real-time trials, and we'll see how that what that looks like. I know they have two pilots that they're working on right now, which is very exciting. What about real world data? How does that factor into this new world order of the clinical trial matching and drug matching? And how is that going to expedite things even more?
Yeah, that is super important because we have all this data from many patients being treated across, different treatment options, including clinical trials and beyond. And that data is sitting in the computers or desks of certain companies, or they're
Yeah,
just in just sitting there collecting dust. And what we know is that we can use that data to develop, cohorts. Now we can really normalize things using AI and beyond, and we can get, control arms as part of that easily. So we don't have to put patients on placebo, right? Straightforward. And this is not a new concept, but no
yeah,
one has done the work. Is like, okay, we are FDA, we're going to use, patient-consented data or real-world data as a regulatory framework acceptable for rare disease or for harder to find biomarkers or things like pancreas cancer, for example. So this is the future, and I think we're seeing some positive trends in that direction. And I feel that also having these what I call these AI pre-screening hubs, which is what we use at Massive Bio. So instead of us, for example, we have all these patients with different cancer types, we don't pull their data constantly because that's such a waste, right? So instead of doing so, we predict when the patient may meet us, and then we help them. The same way you look for, your Uber tells you, you may need a car now, or Amazon tells you you're running out of, your favorite, treat that you always get every month or so. We can do the same, but for analytics with real-world data. So this real-world data can really inform us based on these foundational models of when do we really need care and if we are at higher risk or not versus others, so we can be prioritized and be much more nimble in cancer screening, in cancer diagnostics, in getting the right treatment, you name it. So, but once again, it cannot be a single company, cannot be a single institution doing this testing. It has to be almost like a mandate, like a global mandate, and
Yeah.
say, okay, for
Yeah.
this use case, open the coffers, everyone can read it. We are managing. This is the use case, and there is no more silos here. There's full interoperability, and everyone needs to cooperate on this. I think that's the way we're going to change the future, and I think that's how China is winning the race in that sense because they're like, well, open, everyone opens, right? So we need to be the same in the US and in other countries that have the same frameworks.
Thank you. Yeah. So I think we have time for one last question, and I want to turn back to massive bio a little bit. So um, let's see, where do you see massive bio in 5 years from now, and what would have to be true about the oncology landscape for whatever vision you have for massive bio in 5 years to be realized? I guess it has to do with interoperability, right? So
100%. So that's what
yeah.
we're always at the CMS conferences and talking about things with HHS and beyond. It's all about having real-time, frictionless exchange of information that is patient-centered. Because at the end of the day, that's how we were able to solve the problem is that, I'm too busy, the institution is busy, the sponsors of trials that's not their interest. So we had to make it the patient center. So Massive Bio is going to be built upon patients just using the platform, getting frictionless information and guiding their best care possible by looking at that. And we can compare real data with those patients' outcomes and show that we're able to make those patients live longer, better lives, at least informed lives at the bare minimum. They know their options. They know that they when they look back, they say, I had everything in my toolkit to actually overcome this cancer to the best of my ability. And that's how I see Massive Bio really evolving. And hopefully through collaboration, be part of that activation in real time so the patient can use the platform to get access to the best care possible with the cancer and really make it end to end the best way care that we can deliver.
What a vision. And I hope and pray that that all the stars align and that your vision can come true because the world needs it for sure. With that, is there anything that I have not asked you about that you would like to talk about today that we can end our discussion?
No, you asked me wonderful, insightful questions, and I really appreciate that. It's sometimes hard to take the time to explain all the things that may be, opportunities and things that we can work together. So no, I think it's mostly an invite to collaborate, to be open-minded, and to ask the right questions so we can really change the way that, oncology and overall research is delivered. The future is out for us to build. So it's all a matter of really making it meaningful. And it's not just words, it's real. Like we can actually see those changes now.
Knowledge is power, and what you are doing is democratizing access to information for people who may not have had it before. And we really have to thank you so much for doing that. You and your colleagues, Dr. Bonilla, thank you so much, because it is it. We know it's this is no easy lift for sure, and you're fighting the good fight, as they say, so that one day maybe cancer won't be the scourge it is today. So thank you so much for your time. I could ask so many more questions because this is an area, passion area for me as well. But thank you so much, and have a wonderful day.
Thank you. Thank you. Thank you for the opportunity to talk to you today.